Hello, good time to you. We have a clinical test of the 980 nanometer sugar diode laser device. You've seen the device in the previous video, and now we want to see how it performs in clinical practice. I will use a 400 micrometer tip. The 400 tip that I initiated. We talked about initiation. We said that when we perform an operation such as incision, cutting, and extraction, we need to initiate the tip so that the energy is concentrated at the tip point. And this energy concentration helps us to perform the incision more easily with a lower energy density. Dear Mani, I used a B of C for him. We have a B of C of C. So let's remove the lacy tissue for the 4th and 5th ribs, so that we can have enough space to attach the bracket. We can do a kind of apical flap position, but without a flap. So let's give a position to the lacy tissue apical flap and see it in detail from the perspective of the Nahir. The first Duat's factor we need to pay attention to for this treatment is the width of the keratinized gingiva. I can apically position the gingival tissue using 2 approaches, sometimes this goal. May be achieved in a small way by losing. Sometimes if the width of the keratinized lesion is small and I need to remove, say, 3 millimeter of the lesion, I can use the apical flap position, which is much more labor intensive and may have a similar complication for the patient. Fortunately, here we have a width of 5 millimeters for teeth 5 and 6, which are candidates for our treatment now. For teeth 5 and 6, we have a width of 6 millimeters for teeth 5 and 6 millimeters for teeth 6. This width helps us to perform the extraction in a resective manner. And when we want to do resective work, the easiest way to do it is with lasers. There is a diode. We just need enough time here to allow the bracket to be fixed more apically. Usually, when we do this extraction with a laser, it can even be done in the form of a wire. The bracket can be bonded to the root canal and the treatment can be continued. That means that there is no need to wait for a long time. Our patients do not need to wait for such a procedure in advance. So I want to use the diode laser as usual when I want to. My preference is to use the continuous wave, CW mode, with a power range of about 2 to 2.5 watts. This is generally effective for tissue removal and can work very well for us. Right now, I'm using a continuous wave mode with a power of 2 watts. I can adjust the power here if needed, but if the power is suitable, I'll continue working with this setting. We talked about the Suga laser and mentioned one of its advantages is that I can directly adjust the power from the handpiece itself. I can easily increase or decrease the power right here, and this feature helps me operate much more comfortably. The adjustments I might need to make during the procedure can be done very easily from here. I can also switch between the 2 modes, continuous and pulsed, just as easily from here and from the handpiece. All right, I've selected a power of 2 watts for this removal. I will get everything done. Switching between the 2 modes, continuous and pulsed, is also very easy to do from here and from the handpiece. All right, I've selected a power of 2 watts for this removal. The wavelength of 980 nanometers applies thermal effects so that the woman's dehydration is more limited. I usually take help from a simultaneous wash that only my dear friend can help us have this wash. And well, I also need a section. If I say section, I will use a simple section, a small cream, and we're going straight to the removal. We don't need continuous irrigation. In fact, we only need a small irrigation every few seconds when we sense heat accumulation to cool the area down. Since I want to work in the posterior area, I need to increase the curvature of my tip. I usually do this manually, but fortunately, here we have a device that allows you to achieve this curvature with its help. I use one of the small tools inside the kit to give curvature to my tip, and with such a curvature, I can direct the beam in the posterior area. I was a little nervous. Let's go back here and get back to normal. Thank you. Please don't look at me. Okay, as I said, we have enough creatine here. I'll speak louder so that the sound of the section doesn't bother you. Here I can do the removal with 2 brushes. If my lace is a little thick, maybe it's a translation. I start layer by layer from the top, remove layer by layer, and do it until I reach the desired depth. Those are the places where the sequence of losses is the most. This removal layer by layer from the top of the margin is going to take a long time. In such situations, I usually prefer to perform the extraction in an external boil manner, similar to what we do in a surgical setting, following this pattern. We will perform the extraction at the moment we need it. I will set the device to the tracking mode and I can see the pilot light. Now I will start the extraction at power level 2 continuously. Fortunately, even without a pedal on this device, I can do my pickup very easily with the help of a button. Engraved on the Humphrey itself, the key has also been initiated, so the extraction should proceed relatively smoothly. If you think your extraction isn't fast enough, there are 2 things you can do. You can increase the initiation, meaning you can raise the power. I will continue my work with a slightly higher duration. They like to be a little carefree, so give them time to warm up their side here. Now I can get my impression in a more effective way. So, well, he's done the homeopathy he's been applying. I'll give him a scalpel cut. And I'm very careful with this cut so that they still have at least a 2 millimeter width of keratinized tissue here. I think it's complete in the first period. I'm building a lot to blow your brains out. I'll delete this buff now. The area that needs to be treated is now adequately prepared so that we can position the dental bracket in the desired location. If there was a CL static in mind, I would need to shape the margin of the tissue as well. If necessary, I might also need to perform some osteoplasty in this area. However, here the main goal is just to connect the bracket and the expander to the tooth. Now, let's move on to the second tooth, and I will continue the same extraction technique in a scallop manner on tooth number 5. The only thing to keep in mind is that there should be enough width of keratin in the area. In the end, we will ensure that the keratin layer is sufficient. Badger has more teeth, and in fact, so that the shield is air option. Find this tooth, and this amount will be enough. Now we move on to the second tooth and follow this same pattern again in the form of a scallop on the 5th tooth. The only consideration is that there should be enough width of the curtain to prevent the child from cutting it at the end. I have the impression of the tooth and I receive it from the dia device. But this impression is also important not to touch the surface of my tooth anymore. When the connection is almost completely removed, I may get help from hand tools like a drill or something like that. In fact, I may get help from other devices to remove it. Very good. Let's take this. The work we wanted to do is almost complete. We have now reduced the width of the veneer by about 3 millimeters. I have enough keratin. You can see that on the 6th tooth, I have about 3 millimeters more keratin. On the 5th tooth, I have at least 2 millimeters more. And that's okay because we will have some relapses. In the next few weeks, our keratin will completely heal properly. This removal only gives the orthodontist a window of time to bond his bracket at the desired points and then proceed with the tooth extraction. Since we had the Hinkar irrigation, the restoration will be relatively painless and painless. We received a corrugation here at the level of the cavity in the middle of the thermal effect that the laser creates. Our extraction used thermal and polarization mechanisms, causing slight edge degeneration that needs water reabsorption during healing to return to normal. We asked the patient to maintain plaque control. Initially, the area might appear discolored like any thermal wound. With good area control, the patient should not experience much postoperative pain and can expect smooth recovery. During this first week, we ask our patient to maintain regular plaque control. In this area, it might appear a bit discolored in the initial days, similar to any other thermal wound. One concern that margins usually have is that this wound has a chance of infection. But if you have controlled the area well, the patient shouldn't experience much post-operative pain after this treatment. They can expect a smooth recovery, and I'm mentioning this to reassure the patient that this discoloration in the early days is not a sign of infection, so they shouldn't worry about it. You can expect the poor sigh. And I'm just saying that I'm a patient so that he doesn't have to worry about the infection. I'm just saying that this is a bad thing in the first few days, and this is not a sign of the infection, so our patient doesn't have to worry about it. Well, thank you very much. It turned out really well and our work is complete. I'm going to return the unit, so you can proceed. In my opinion, you should connect the bracket at the earliest opportunity. You even have the option to do it today, if you can adjust the time, to easily connect the bracket. Thank you very much. And I also appreciate your support, as well as the Nutrident's company Matate and the Sugat laser team for coordinating the video recording. I really appreciate it.